diabetes. And now we will proceed to the Symposium 3 with the title of Pleiotropic Effect of SGLT-2 Inhibitors. In the session, we will explore various metabolic effects of SGLT-2 inhibitors from weight reduction to the other benefits beyond glucose control.
We are pleased to introduce our distinguished speakers for this session. Our first speaker is Prof. Silvio Inzucchi, MD from Yale University. Next, we have Dr. Wismandari, PhD.
This plenary session will be moderated by Dr. Wismandari, PhD herself. And Professor Silvio Inzucchi, MD, will have 40 minutes of presentation time, while Dr. Wismandari will have 20 minutes of presentation time. And it will be followed by another Q&A session to end all the presentations. Before we begin, please allow us to display the CV of the speakers. And for Dr. Wisma, the time and place is yours.
So thank you very much, Dr. James, for the MC. Good morning, everybody. Assalamualaikum warahmatullahi wabarakatuh. Professors, doctors, it's been an honor for me to be here this morning. So today we would like to give a talk about, I think it's a very famous drugs right now. It's SGLT-2 inhibitor. And thank you very much for Hetero as well, who make this happen today. So for the first speaker, I think we were all very happy to hear him to be here. Unfortunately, he's not here in present, but it doesn't matter because he's here online. So let me see the CV of him, please. So I think most of us is very familiar with this person, Professor Silvio Inzucchi. We see a lot of his work, and he's a professor in Yale University. So I think there is no doubt for us to have a big discussion after this. So please, Professor Silvio, I think the time is yours for about 40 minutes. Thank you very much for coming, Prof. Inzucchi.
Thank you very much. And it's a pleasure to take part in this symposium. Sorry I cannot be there live. I say good morning to everyone. It's evening here on Saturday. I was asked to speak about the pleiotropic effects of the SGLT-2 inhibitors. And what I'll try to do is to develop a story about how these drugs were developed, how they were initially used for patients with type 2 diabetes, and then we essentially stumbled upon some very important beneficial effects as related to the heart and the kidney, and that led to this further study in specific clinical trials that involve patients with heart failure and with chronic kidney disease, irrespective of the presence of diabetes. And then these studies, which now number several dozen and include almost 200,000 patients in these clinical trials, have given rise to new notions about how these medications work and what other beneficial aspects we might expect to using them over the coming years. So these are my disclosures. And the way I've structured my comments this morning is to first present a background of the SGLT-2 inhibitors. We'll then review the cardiovascular and the kidney effects of these medications, other potential benefits. We'll circle back to the treatment guidelines from international organizations, both diabetes, heart failure, and chronic kidney disease spaces. We'll describe some prescribing pitfalls and pearls for those of you that are not yet using these medications extensively. And we'll touch upon what we still don't know and what we need to know about the proper use of these medications. So let's start with the background. So the SGLT-2 inhibitors have been out in Europe and Asia and the United States since about 2013 and 2014. But it's important to know that an earlier SGLT inhibitors would actually block both SGLT1 and 2 was fluorescein, which was used extensively in research studies, mainly in animal investigations of glucose metabolism. And there are many dozen studies that I found extending from the 1930s through the 1990s using this drug fluorescein, which never made it to market, had some exposure in human studies, but was mainly a laboratory device. And here's a study from my institution, and you'll recognize some of the famous researchers on this paper, including my colleague now, Jerry Schulman, Luciano Rossetti, and Ralph DeFranzo, who used fluorescein in diabetic rats in order to lower the glucose levels into the normal range to demonstrate that in the setting of not increasing or decreasing insulin supply or insulin sensitivity, that the correction of hyperglycemia in these laboratory animals, these diabetic rats, could actually restore insulin-mediated glucose uptake. So this was one of the first demonstrations that when you lowered plasma glucose concentrations in diabetes, you ameliorated glucose toxicity. It's a very difficult study to do if you gave insulin because of the measurements of insulin and glucose that was required in these studies. So the fluorescein molecule was an interesting tool in that it lowered glucose but did not change any parameters in terms of insulin supply or insulin action. Now, after several decades of study, a syndrome known as familial renal glucosuria began to be identified in the 1970s and 1980s. And this is a benign condition that ultimately was found to involve a defective transporter in the proximal nephron. And this transporter was later termed sodium glucose cotransporter number 2. And in the defect, it allowed for chronic glucosuria. And interestingly, these patients had no abnormalities of their kidney function, and interestingly, were somewhat protected against the development of diabetes and obesity. And further investigation into this transporter and the gene that codes the protein that is this transporter led ultimately to the discovery of the pharmacological SGLT-2 inhibitors. Now, the physiology of the nephron as related to glucose metabolism is seen here. Glucose is filtered by the glomerulus. There are actually 2 transporters in the proximal nephron, SGLT1 and 2, but the major player is SGLT2 because it's responsible for 90% of the glucose reabsorption from the glomerular filtrate. When these transporters are working, there is essentially no glucose excretion. If the SGLT2 transporter is defective, as in familial renal glucosuria, or if we introduce an inhibitor pharmacologically, then the transporting system is overwhelmed and glucose excretion occurs. And when this inhibitor is blocked pharmacologically, the net result is a loss of about 70 to 80 grams per day of glucose, which translates to approximately 300 kilocalories of loss per day. And this explains not only why plasma glucose concentrations and, of course, hemoglobin A1C are reduced when an SGLT2 inhibitor is applied, but also why there may be some weight loss, certainly not extensive as one might see with the GLP-1 receptor agonist, but there is modest weight loss that is induced by this class of medications. Now, interestingly, the healthy nephron will excrete glucose when the transporters are overwhelmed with a glomerular filtrate concentration of 180 milligrams per deciliter, i.e. the plasma glucose is 180, the glomerular filtrate is 180, and the transporter no longer function adequately to keep glucose out of the urine, and therefore glucosuria occurs. In type 2 diabetes, it's been demonstrated by DeFranzo and others that the threshold for glucose excretion is actually increased to 240 milligrams per deciliter, meaning that the diabetic kidney does not get rid of glucose adequately. When sodium glucose co-transporter 2 inhibitor is applied to these patients, the glucose threshold is reduced well under the normal range down to approximately 70 milligrams per deciliter. So interestingly, in patients with diabetes who have plasma glucose concentrations under the normal range, so in the 70 to 80 milligrams per deciliter range, or if these medications are given to normal individuals, there remains glucosuria. Now, obviously, the patients are not developing hypoglycemia with these medications. That's not seen. And the reason for that is that there are obviously other compensatory mechanisms, such as a reduction in insulin secretion that allows for the maintenance of a low normal plasma glucose concentration. Now, these drugs were initially studied in the early 2000s, and I like this study because it's a classical SGLT-2 inhibitor diabetes trial, giving dapagliflozin to patients who were already treated with metformin and comparing it to the addition of glipizide, a sulfonylurea. And you can see in the left upper panel that the hemoglobin A1C is reduced more quickly with the sulfonylurea. These tend to be more potent in terms of glucose and A1C reductions, but at the end of a year's time, the hemoglobin A1C is the same. So ultimately, dapagliflozin was as potent as glipizide when applied over 1 year. Modest change in body weight, as you can see, about 2 to 3 kilograms. And you can see in the upper right that there is more hypoglycemia, of course, with the sulfonylurea mechanism of action. And this is the possibility of discontinuation of the medication much higher over dapagliflozin. So I think at this point in 2011, 2012, 2013, before these medications were actually released to the, they were felt to be modestly effective glucose-lowering agent with a very interesting mechanism of action, but there was no suspicion at this point that these drugs would radically transform the practice of diabetes 4 or 5 years down the road. The first meta-analysis was published in 2013, looking at studies involving DAPA, CANA, EMPA, IPRA, and losilgliflozin, the final 2 being available in Asia, but not in Western Europe or the United States. And you can see that on average, the hemoglobin A1C reductions were quite modestly reduced on the order of 0.6 to 0.8 percentage points. As mentioned, there was a compensatory decrease in body weight as a reflection of the calorie losses on the order of 2 kilograms, and modest reductions in systolic and diastolic pressure, about 4/2 millimeters. The SGLT-2 inhibitors were released in the United States in 2014 with canagliflozin. These were prescribed as adjuncts to diet and exercise, mainly or say exclusively to improve glucose control and hemoglobin A1C. Importantly, these were not indicated in type 1 diabetes. They actually, as we'll see later on in my lecture, they actually work in type 1 diabetes, but there are significant safety concerns, so they were never approved for use in type 1 diabetes, and at least in the United States are not allowed in patients other than type 2 diabetes for glucose lowering. We'll talk about other indications as well. Now, these are the medications that are currently available in the United States: canagliflozin, dapagliflozin, empagliflozin, the newer ertugliflozin, bexagliflozin, and an interesting compound, which is a co-inhibitor of both SGLT2 as well as SGLT1, known as sotagliflozin. The 2 most commonly prescribed SGLT2 inhibitors are DAPA and empagliflozin. Now, before the clinical trials were released, and we'll talk about them extensively related to the dramatic kidney and heart benefits of these medications, this was the risk to benefit ratio that most of us presumed when thinking about using a flozin, an SGLT2 inhibitor, in the time period of 2003 2014 and 2015. Again, a modest reduction in A1C, weight, blood pressure, low risk of hypoglycemia, and interesting decreases in albuminuria, as well as some beneficial lipid effects. These medications increase urinary output, and therefore, particularly in older individuals, particularly older males with benign prostatic hypertrophy, urinary frequency could become a problem. There is a risk of dehydration. These are drugs that induce an osmotic diuresis, and therefore patients have to keep up with their fluids, particularly in an aging population. The GFR, the estimated glomerular filtration rate, does decrease about 5 to 10%, but this is now known to be reversible and not necessarily deleterious for kidney function long term. The main side effect is actually genital yeast infections, and this is simply a reflection of the mechanism of action of glucose in the urine. This is more of an issue in women than in men, although even in men, particularly in uncircumcised men, there can be a significant increase in candidal balanitis. The question of urinary tract infections was initially a concern, although most of the trials have not seemed to show any increase in risk, at least for serious UTIs. And I alluded to very briefly the notion of using these medications in type 1 diabetes. One of the major concerns has been the risk of euglycemic DKA, and we'll talk about that later on in my lecture. One of the drugs, canagliflozin, the first one, was initially associated with an increase in fracture risk and modest increases in LDL-C concentrations, although that has not panned out to be any significant concern. So as with any medication with diabetes, even metformin, sulfonylureas, DPP-4 inhibitors, and even GLP-1 agonists, there are benefits and risks, there are pluses and minuses to their use, and the proper use of any of these medications is based on the clinical judgment of the clinician, the physician, trying to match the best drug to their individual patient. Well, let's turn now to the cardiovascular effects of the SGLT-2 inhibitors, and we start with the EMPA-REG outcome trial, which was published now 10 years ago. It's surprising to say that, but it's been 10 years since we presented the data at the Stockholm meeting of the European Association for the Study of Diabetes in September of 2015. And what we reported was a 14% relative risk reduction in MACE, major adverse cardiovascular events, led by a 38% reduction in cardiovascular death and a 35% reduction in heart failure hospitalization. Now, these are all relative risk reductions, certainly not absolute risk reductions, but they're landmark findings because this is the first time that any glucose-lowering agent, when used in type 2 diabetes patients at high cardiovascular risk, actually improved cardiovascular outcomes. Those of you that have been involved with diabetes treatment or diabetes clinical trials for the past several decades recognize the frustration that many clinical trialists had in the type 2 diabetes space, not being able to demonstrate that glucose control could have any substantive impact on reducing the major risk of mortality in these individuals, which is cardiovascular disease. EMPA-REG outcome was the first study to turn that notion on its head. In other words, yes, we can improve cardiovascular outcomes with glucose-lowering medications. Quickly, I wanted to show other studies in the SGLT-2 inhibitor field that equally demonstrated important benefits on MACE and more frequently on heart failure hospitalization and the progression of chronic kidney disease. I'll first show you the MACE outcome. This is a composite of 14 or 15 trials from diabetes, as well as heart failure and chronic kidney disease trials that we'll talk about later on. But the best estimate of the point estimate for MACE reduction is 9% relative risk reduction. For CV death, it's about 14% risk reduction. MI, not significant, but at 5%. And essentially no effect on stroke. So all of the effect on MACE appears to be driven, or I should say most of the effect on MACE appears to be driven by the effect on cardiovascular death. Now, I alluded to sotagliflozin previously. This is that SGLT-1 and 2 inhibitor. The SCORED study looked at patients with type 2 diabetes and CKD, and its primary endpoint was heart failure hospitalization and cardiovascular mortality, and that was reduced by 26%. And the secondary outcome of MACE in this trial was reduced by 23%. Now here, in contradistinction to the mono inhibitors of SGLT2, both myocardial infarction and stroke were significantly reduced. I can't tell you why this is, why blocking SGLT1 might have this benefit. This is a single study, but there is a bit of an outlier here in that there is a stronger MACE effect on MI and on stroke with sotagliflozin as compared to the more traditional SGLT2 inhibitors. We've touched upon heart failure, and this is one of the early meta-analyses when there were 3 main trials, one with CANA, one with EMPA, and one with dapagliflozin. And we can see at the bottom of the slide that in patients with a history of heart failure, the reduction in heart failure hospitalization was reduced by 44%. And this was almost identically seen in patients without a history of heart failure. So this is a radical notion. Not only were these medications helping people stay out of the hospital who had heart failure, but actually preventing new heart failure from developing. So heart failure prevention, which again is a novel notion in terms of diabetes management. You'll notice that this again is from the EMPA-REG outcome trial, that the divergence of the event curves for heart failure hospitalization was exceedingly early. I think the data suggested that at 1 month, there was already a significant effect, presumably a hemodynamic effect, probably not having anything to do with atherosclerosis. And we'll talk about mechanisms toward the end of my lecture. Now, these dramatic findings, particularly as related to heart failure, I mean, we're talking about a 35% relative risk reduction versus a 14% relative risk reduction for MACE. So the heart failure effect was much more potent than we saw in atherosclerotic endpoints. And this led cardiologists, and specifically the heart failure community, to wonder the following question: if this helps patients with diabetes prevent heart failure or improve their heart failure outcomes, could this potentially improve my patients who don't even have diabetes? Is there something about an SGLT2 inhibitor that has nothing to do with this glucose lowering or its effect on hemoglobin A1C? Now, the first study to look at this question was DAPA-HF. So this is a trial of heart failure with reduced ejection fraction, or HFrEF, and dapagliflozin versus placebo was prescribed to these patients. And you can see that the relative risk reduction was 26%. And very important to note that the point estimate for the treatment effect was no different in patients with or without diabetes. Well, this is a shocking notion now. This is a diabetes drug whose effects are beyond glucose lowering, that not only helps people with diabetes prevent heart failure admissions, but also patients with heart failure without diabetes. Now, there were a series of other trials using DAPA and EMPA and ultimately sotagliflozin, and each of these showed significant risk reductions in the primary endpoint, which tended to be the composite of CV death and heart failure hospitalization. And here in this meta-analysis, there was a 23% relative risk reduction. And just like I showed you with DAPA-HF, no heterogeneity between patients with or without diabetes. In other words, there's no significant risk modification by the presence of diabetes in these clinical trials. What about the kidney effects of these medications? Again, hearkening back to the renal outcomes from the EMPA-REG outcome trial. This was also surprising. There were some concerns initially. Many of you may remember when these drugs first came out that there was some worry that they might, if anything, harm the kidneys. All that glucose going through the tubule going to lead to harm. And actually, the answer is no. In fact, there's a benefit. Here's a 39% risk reduction in worsening nephropathy in the EMPEREG outcome trial. Here, the endpoint combining the development of new macroalbuminuria as well as a doubling of serum creatinine or the development of end-stage renal disease. So there is a significant benefit to taking empagliflozin over the 3 to 4 years of the trial. And each of these components of the kidney outcome in EMPEREG outcome was positive. The total composite, just the development of high levels of proteinuria, the doubling of creatinine, and the development of end-stage renal disease. There is this interesting phenomenon when you're using eflozin in patients with or without renal disease of an initial dip in the GFR, and I mentioned this before, an initial hemodynamic reduction in glomerular filtration that eventually stabilizes, and at the end of the clinical trial, the renal function, if anything, is better on the patients who dipped, who took the active therapy, the SGLT-2 inhibitor. And each of these studies have shown more or less the same thing, an initial loss of renal function, then stabilization, and ultimately a win over being on placebo. In an early meta-analysis involving 5 diabetes clinical trials using an SGLT-2 inhibitor, the ultimate effect was a 38% risk reduction in the progression of CKD. And just like in heart failure, this led nephrologists to begin to wonder, hey, if this is a medication that helps patients with diabetes and the effect does not appear to be mediated through glucose, could it help my patients with CKD even if they do not have diabetes? Well, the answer is yes. In Credence, which was the first of the renal outcome trials looking solely at patients with type 2 diabetes, there was a significant benefit of about 30%. But in the subsequent trials that included patients that did not have diabetes, so both patients with and without diabetes were included, DAPA-CKD and EMPA-KIDNEY using dapagliflozin and empagliflozin respectively, more than 10,000 patients, large effects, 39%, 28%, in these renal composite outcomes. And this is an effect that, as we pointed out with the heart failure trials, appeared to be agnostic of the presence or absence of diabetes. So here we look at the CKD progression outcome from the largest meta-analysis from the SMART-C consortium, looking at all of the SGLT2 inhibitor clinical trials across diabetes, heart failure, and CKD. And the benefit is a 38% reduction in diabetes and a 31% reduction in patients without diabetes. And even acute kidney injury, there were significant benefits in both diabetes and non-diabetes patients. Now, what about other potential benefits? These are drugs that reduce weight, lower hemoglobin A1C, improve blood pressure, lead to improvements in cardiovascular and kidney effects. What about using them in other populations of patients beyond heart failure, CKD, and type 2 diabetes? Well, as I mentioned before, there has been some interest in using these drugs in type 1 diabetes. And in fact, they do lower hemoglobin A1C, although more modestly than we see in type 2 diabetes, on the order of about 0.3 percentage points. However, the time in range when using continuous glucose monitoring is increased by about 10%. And that's a large effect of those of you that use CGM in your patients. And in addition, there is a modest but significant reduction in body weight. We know that many patients with type 1 diabetes these days are becoming overweight, if not obese, and also about a 10% reduction in total daily dose of insulin, which might predict future decrease in risk of hypoglycemia. So there are modest benefits, but on the other hand, there is this concern of what I mentioned before, diabetic ketoacidosis, often euglycemic, so patients are not as hyperglycemic as in traditional DKA. And this is always significantly higher. The numbers are small, but always significantly more in patients on the flozin as opposed to placebo. And this led most regulatory agencies to deny registration for these medications for use in type 1 diabetes, which is unfortunate because in this real-world study of almost 1,000 patients with type 1 diabetes who were treated with an SGLT-2 inhibitor, compared to almost 200,000 patients without use of an SGLT-2 inhibitor, there appeared to be at least a suggestion of similar benefits as we see with type 2 diabetes. So stay tuned. I think there are some investigations exploring the safety of these compounds in a type 1 diabetes population. And I can only run through these quickly, but there are myriad other potential, and I would underscore potential. These are not clinical trials looking at these endpoints, but simply post hoc analyses of previous randomized clinical trials suggesting benefits. All-cause hospitalizations are increased, even those that don't involve kidney disease and heart failure. Don't know why. Atrial fibrillation appears to be decreased. 3 issues that might involve the renal effect of these medications in terms of handling of various electrolytes and other compounds: prevention of hyperkalemia, prevention of gout, prevention of nephrolithiasis, and we've demonstrated a prevention of obstructive sleep apnea. Type 2 diabetes is prevented. We've demonstrated a 32% relative risk reduction in the DAPA-HF trial, which, as you might recall, is equivalent to the 31% risk reduction that we demonstrate, that others have demonstrated with the use of metformin in the diabetes prevention program. Steatosis and MASH are decreased. Sp.PD outcomes are improved. And some have even shown a potential role in preventing dementia and certain of the ocular manifestations of diabetes. So right now we have a drug that improves hemoglobin A1C as well as cardiovascular renal outcomes, but I've showed you a list of about 10 or 11 potential benefits of these medications, and I think that more study is necessary. Now, in the earlier guidelines, prior to the development of the SGLT-2 inhibitor cardiovascular outcome trials, the drugs were essentially used as glucose-lowering agents, similar to an SU, a TZD, a DPP-4, or a GLP-1, or even basal insulin. And this was the strategy that we recommended, is that you would start with lifestyle and add metformin, and then layer medications, dual therapy, triple therapy, and ultimately combination injectable therapy. And this was driven by the hemoglobin A1C and was obviously very glucose-centric because we had no data that there was any differential effects of one of these drugs versus the others in terms of cardiovascular and kidney disease. Well, fast forward to 2025, now 10 years later, and the guidelines have clearly evolved over time. And right now, this is one that I pulled from the American Diabetes Association. Instead of starting necessarily with metformin, we actually asked the question about what is the comorbidity that the patient is at risk for, and what are we trying to prevent? In other words, if the patient has ASCVD, either an SGLT-2 inhibitor or a GLP-1 agonist. I've not gone into the GLP-1 agonist data, but it's equally striking in terms of the MACE effect. So either or, and some would say both. If there is heart failure, the data suggests that an SGLT-2 inhibitor is the best initial agent, and in the presence of CKD, again, an SGLT-2 inhibitor. Now, once these issues are addressed, once you've apportioned the medication that is most apt to prevent the complication that you're trying to prevent in your patient, then you can go back to the 2015 strategy, which is looking at weight management and glucose management and seeing which drug may be better for your patient. And obviously, the SGLT-2 inhibitors could be used on this side of the algorithm as well, as can be the GLP-1 agonist, but there's no preferential effect for one or the other, except, of course, for the GLP-1s at high doses, which have substantive weight loss reduction. These medications are now in the heart failure guidelines. So these are from the American Heart Association and the American College of Cardiology in the setting of HFrEF an SGLT-2 inhibitor is foundational therapy. In the situation of HFpEF, although the degree of evidence is class 2A as opposed to 1 for HFrEF, we have an indication in this population of patients as well. And finally, in the KDIGO guidelines for patients with CKD, again, irrespective of the presence of diabetes, an SGLT2 inhibitor should be considered one of the foundational therapies in addition to RAS blockade. What about some pitfalls and pearls to using these medications? You remember the original FDA indication here in the United States, and now we have different indications such as MACE reductions for canagliflozin, heart failure and mortality reduction for dapagliflozin, cardiovascular mortality reduction in empagliflozin, and then specific CKD with CANID's DKD, with EMPA and DAPA it's CKD, and heart failure effects as well with DAPA and EMPA, and sotagliflozin has a strange label looking at just heart failure in patients with or without diabetes. It was actually not used as a glucose-lowering agent, although it obviously has the same glucose-lowering effect as other SGLT2 inhibitors. So we tend to favor these medications when CKD or heart failure are present, or when CVD or obesity are present, although obviously the GLP-1s may be stronger in this regard, particularly as regards to weight. And we avoid them in patients with recurrent genitourinary infections, especially if there is ongoing instrumentation, Foley catheters, stents, etc. We avoid them for the most part in type 1 diabetes and those patients with latent autoimmune diabetes of adulthood, particularly related to the EDKA risk, the euglycemic DKA risk. Patients that have orthostatic hypotension, the frail elderly, those with advanced PAD who've had amputations. I didn't mention this, but one of the studies, Canvas with canagliflozin, showed a doubling of amputations, not been seen in the other clinical trials, but there are still some lingering concerns about the potential effects of these medications in those patients with severe peripheral arterial disease. And those post-marketing reports of Fournier's gangrene have led to some label updates in the entire SGLT2 inhibitor class for non-use in patients with that previous diagnosis, or those that may be at high risk. There are many tricks, as we call them, in terms of proper use of these medications. For instance, in those patients who have genital yeast infections, they are treated routinely, but caution is certainly necessary in patients with prior genital yeast infections, informing them of the risk, particularly women with previous candida vaginitis, uncircumcised men with previous candida balanitis. We adjust insulin and sulfonylureas if the patient is already under tight control and we're adding these medications to that regimen. We also adjust other diuretics based on the volume status of the patient. We tolerate small reductions in GFR up to 10%. We recall that the duration of action of these medications is more than just the half-life. So there is ongoing glucosuria for 1 to 2 days after discontinuing the medication, and that needs to be considered for holding the medication 3 days prior to surgery because of that DKA risk, and certainly during moderate to severe illness. Many caveats regarding the proper GFR at which point the SGLT2 inhibitor should not be prescribed or should be stopped. It's a bit confusing. Each of the labels, and this basically reflects the US FDA labels, but there are variable GFR cut points where each of the flozins should not be prescribed. It gets a bit confusing. My personal recommendation is that you use them freely down to 30 and cautiously under 30, although the nephrologists now are recommending that even under 30, they can be continued to the point of end-stage renal disease. The important caveat here is that the drugs don't tend to lower glucose under about 30 to 45 GFR, because you need a certain amount of glomerular filtration in order to excrete glucose. So while they have heart failure and CKD benefits, they won't have glucose lowering benefits the lower the GFR is. And to finish up, the point of mechanism is something that remains very, very controversial. So what we don't know yet about the SGLT2 inhibitors, we know what they do, but we just don't know how they do them. How do they improve these clinical outcomes? This would take another hour to discuss all the theories, but there are probably volume effects in terms of the glucosuria and the osmotic diuresis. There may be direct effects on the kidney and the heart, the vasculature. I think this is a big black box in terms of how the SGLT2 inhibitors induce these myriad but striking benefits on cardiovascular and kidney outcomes. Can these benefits be extended to lower risk populations? Well, I showed you the data from EMPA-REG outcome, and certainly if you're preventing heart failure in patients without heart failure, that's an important early benefit. So that's taking a patient that does not have a disease and preventing that disease from occurring in the first place. One might even say that prevention of any loss of GFR or the development of macroalbuminuria is an early effect, a lower risk population, and that has certain benefits on the prevention of long-term chronic kidney disease development. Are they additive or synergistic to the GLP-1 agonists? This is a very important question because we're using both of these classes in patients with diabetes at high cardiovascular risk. This again is from SMART-C, the meta-analysis of a couple of dozen clinical trials, and you can see that there is no heterogeneity between those patients with baseline use of a GLP-1 agonist in these clinical trials of SGLT2 inhibitors, suggesting to the authors that the drugs don't have any differential effect in patients with or without GLP-1 receptor agonist therapy, indicating that the results are additive. In other words, perhaps not synergistic, but additive, that you can expect a certain incremental improvement in cardiovascular outcomes and even renal outcomes with one drug, and then an incremental improvement beyond that. We've just published the SOUL data, and this is a secondary paper from Nico Marks, who demonstrated that in patients in SOUL, which looked at oral semaglutide, those individuals who came into the trial with an SGLT2 inhibitor seemed to garner nearly as much benefit as those who did not. So again, the presence or absence of an SGLT2 inhibitor is not a risk modifier as regards to the benefits of the GLP-1 agonists, again suggesting that the results are additive, not synergistic necessarily, but they don't abrogate each other as well. Can we mitigate the risk of euglycemic DKA to allow safe use of these medications in type 1 diabetes? I think that's a really important question, and there are some clinical trials, as I alluded to before, to try to figure that out. And I think one of the most important questions is, how do we get these medications and other evidence-based therapies, such as the GLP-1s, to patients with type 2 diabetes who would optimally benefit from them? I've seen data from Europe, I've seen data from the United States, not yet from Asia, suggesting that less than 20% of patients who require these medications based on the guidelines actually are using them. And I think some of this involves cost, of course, but we need help from implementation scientists to assist us in getting the right medications to the right patients. So let me conclude. The SGLT2s are modestly effective glucose-lowering drugs that have been around for about a decade, and we're using them for patients with type 2 diabetes. In these cardiovascular trials, signals emerged that these medications could reduce the risk for CV death, heart failure hospitalization, progression of CKD, initially in type 2 diabetes patients. And these benefits were seen as distinct advantages over older diabetes drugs, which could never be proven to reduce cardiovascular outcomes, as did the SGLT-2 inhibitors. And this led to a remarkable change in the guidelines, which now are not focused solely on hemoglobin A1C, but on the comorbidities in patients and which drugs may be best to reduce the risk of those comorbidities going forward. And then over the past 5 or 6 years now, the benefits of these drugs have been extended well beyond diabetes to those with heart failure and those with CKD, and the effect is the same. So there's no risk modification from the presence or absence of diabetes. And finally, the SGLT-2 inhibitors, I hope you agree, have transformed our treatment landscape for patients with diabetes as well as for patients with heart failure and chronic kidney disease. Thank you so much for your attention this morning.
I think it's going to be really easy for me to continue the next talk because I think it's already given by Professor Inzucchi as well about this topic. My topic will be practical usage of SGLT-2 inhibitors. It's about tips and tricks. And I think he's already tell us about the pitfalls. I think it's almost the same. So I'm going to show you first one. My first slide, I think it's already seen by Professor slides before, but it's a little bit different. This one from the different references. We can see the benefits of the SGLT-2 inhibitor. There are a lot. There is no doubt because he's been talking about last 45 minutes to show this data about lowering A1C. The weight loss is incredible, and also blood pressure is decreasing, decreasing albuminuria, decreasing cardiovascular and cardiovascular risk, and CKD and DKD risk, and ESKD and cardiovascular events. And there is no risk of hypoglycemia, and it makes a longer duration. It's going to be cost saving and also cost effectiveness. But on the other side, we also have to talk about the risk, as also have been mentioned by Professor Inzucchi, that there is genitourinary infection, and also probably there might be a postural hypotension, might be because of the loss of the water. And also slightly increase of the risk of DKA and concern about lower risk of amputation, which is only by canagliflozin, and also mentioned by Professor that increasing the risk of fracture. So this is the picture. I don't know whether you can see this or not, but we have to think about whether this patient is green light for SGLT2 therapy or yellow or even red light. For the green one, I think it's already mentioned again. You have to mention about the risk of cardiovascular. There's a calculator for that. So if it's 10% above, then it's really a indication for SGLT2 inhibitor. Heart failure, established ASCVD, TKD or CKD, these are a green light for using SGLT2 inhibitor. And also, if you want to use the combination, again, calculate the risk of cardiovascular, which is all above 10, CVD, heart failure, or CKD. If you want to combination with other drugs, they're also a green light for SGLT2 usage. Young onset of type 2 diabetes, 18 to 40 years, unless planning pregnancy. Overweight or obesity, and the absence of GLP-1 receptor agonist, and vulnerable for effects of hypoglycemia. If you see your patient with these kind of condition, there will be a green light for using SGLT2 inhibitor. What about the yellow light? Yellow light if the patient is frailty, older people, and they have a cognitive impairment, ketogenic or doing very low calorie or low carbohydrate diet, BMI is less than 25, and also recurrent genital mycotic infection or UTI recurrently, symptomatic hyperglycemia, history of Sp.PD because of the risk of lower limb amputations, and the calculator risk is below 10%. So it's not contraindication, but there is a consideration whether the risk and benefits, which one is bigger, the risk or benefits. Oh, sorry. And the red light, if the patient is in acute illness or in dehydration condition, current or previous diabetic ketoacidosis, low beta cell functions, which is low C-peptide levels, rapid progression to insulin within 1 year, excessive alcohol intake, suspected LADA, chronic pancreatitis, and type 3C diabetes, suspected pancreatic cancer, pregnancy, planned surgery or procedure, type 1 diabetes, even though the study is already getting in there to the type 1 diabetes, and unclear diagnosis of diabetes. So in this condition, you have to think very careful whether the SGLT2 is good or not. But in this condition, they said it's a red light or do not prescribe the SGLT2 inhibitor. In the simple way, we can say the best candidate is type 2 diabetes with atherosclerotic cardiovascular disease or at least in multiple cardiovascular risk factors. CKD with the eGFR above 20 with or without diabetes. Heart failure, even reduce or preserve. And you have to consider in the type 2 diabetes with poor uncomplicated or asymptomatic urinary infections. Patients with history of genital mycotic infections, recurrent UTI, elderly with volume depletion, hypoglycemia or low intake. And avoid or use with caution patients with active on or unresolved complicated UTI or ongoing genital mycosis, severe acute illness, before elective surgery. At least you have to discontinue 3 days prior. So these are the clinical indications. We have the setting of type 2 diabetes with CKD, type 2 diabetes with CVD risk, or just type 2 diabetes. You can see the criteria here is the albuminuria is above 200 and the eGFR has to be above 20. There are a lot of supporting evidence, especially the famous one, Credence, DEPA-CKD, and also IMPA kidney. Type 2 diabetes with CVD risk, you have to see whether there's a history of myocardial infarction or stroke, multifascial of CAD, single fascial with above 50% narrowing, PAD or unstable angina, 50 years or 2 and above cardiovascular risk factors. And if you see a type 2 diabetes with suboptimal A1C, despite lifestyle and other agents, and a lot of supporting evidence as well. Oh, sorry. And also there is another clinical indications without diabetes, like there is a CKD or heart failure. Even they don't have CKD, they don't have diabetes, there are an indication because we have a lot of supporting evidence like DAPA-CKD, IMPA kidney, and DAPA-HF or Emperor reduce and Emperor preserve and deliver. So we have learned about the indication, what kind of patient that we're going to give, and now how we're going to get it, how we're going to give them, and what time. The timing is the best one. We have a standard care to help us. There is a standard care from ADA, which is already showed by Professor Inzucchi as well. We can see on the left side, which is the red one, and also on the right side, which is the orange one. We can see if you focus on AS, CVD, heart failure, or CKD, only 2 major anti-diabetic drugs, which is already approved by many studies, GLP-1 receptor agonist or an SGLT2 inhibitor. But on the other hand, on the orange sides, we can see if you focus on like the previous guideline, like 2015, like Professor Inzucchi mentioned, we focus on weight management. And also if you want to achieve glycemic control better, then there are a lot of priority as well. So this is, I believe that Professor Inzucchi didn't show because this is ours. This is local one. This is for Kenny, Indonesian Endocrinologist Association in 2024. It's almost the same. If we see a type 2 diabetes patient and we and we see that there is an ASCVD, CKD, or heart failure, or in at least high risk, then we split the patient into two groups. If it's yes, then we go for the algorithm, and then if it's no, then we have another algorithm. We see the first one, if they do have cardiorenal risk reduction, this is the algorithm. Oh, sorry, it's supposed to be white. This is the algorithm. I think it's almost the same like ADA, but we do it in a different way. Almost the same here, and also the preference of the drugs is the same as all. And if we see we want to focus on the weight management or glycemic control, this is the choices. You can see maybe the difference between the America is we still have the sulfonylurea because we still think about the access or the cost. As we see on the ADA, they don't have this kind of issue, which is in our country is very, very important. So what is the drug's choice? I think it's already mentioned, but maybe we could have a deep look about the drugs, about the dosage. If we talk about empagliflozin, they have 10 and 25. If you want to focus on glucose lowering effect, then you're going to focus on 25. But if you want to focus only for the DKD or for heart failure, you can have for 10. So if you go 25, but the eGFR is already like, let's say 25, you will not have the lowering effect as good as if they still have the eGFR above 30. The PPOM have approved for 45. The eGFR 45, below that it's not approved by the BPOM. And for the initiation, there is some indication to use if it's above 60. For the dapagliflozin, there is no difference between the glucose lowering effect or the heart failure. Also for the DKD, the dosage is only 110 milligrams. For the CANA, they do have 100 and also 300 if you want to focus on the glucose lowering effect. For the ertugliflozin, which is we don't have it yet because it's still quite new, they do have a dosage 5 until 50 milligrams. So after we talk about the benefits, as I mentioned earlier, that we have also talked about the risk of the other one, which is most of them doing the genital infections, urinary tract infections, euglycemic diabetic ketoacidosis, and also amputations. The amputations, as I mentioned before, is only for canagliflozin, and there is no clear evidence how it happens, the causality. So I think there is no worry too much about this. But for these two up here, we still have something to be worried. So that's why we need to careful very much about this genital infection and urinary tract infection. So the tips and tricks will be, if you talk about renal function, start safely when it's eGFR 20 and continue until the patient goes to dialysis or transplant. Expect the small initial, less than 30% of dip of the eGFR within 4 weeks, and it's not harmful, already explained by Professor Inzucchi, and minimize the early drop by doing refueling diuretics, ensuring hydration, avoiding nephrotoxin or contrast at the same time when you start the SGLT-2 inhibitor. As a general, inform the patients that there will be an increase in diuresis. There's no worry about that because that's what SGLT-2 inhibitor works. Educate the patients about hygiene, about hydration, early recognition of glucose, about genital urinary tract infection symptoms, and avoid very low carbohydrate or ketogenic diets concerning about the DKA, euglycemic DKA. And also we have to pay attention about the sick day rules, which is they have to be informed about this to stop the medication, to stop this SGLT-2 inhibitor if you cannot eat, if the sick is severe, if you go into the hospitalization, tell them to stop this SGLT-2 inhibitor. And for the elderly, especially if he's above 70 years old, the benefit is similarly. So don't be afraid do not hesitate to use SGLT2 inhibitor if the patient is elderly. So as a take-home message, the practical uses of SGLT2 inhibitor, first, you have to identify the eligible patients. Think about the indications, but don't forget about the contraindication as well. And choose the right patients, the right dosage, and also the right time when to initiate. Adjust the dose and continue accordingly. Stop temporarily during illness or surgery, and anticipate the adverse event by doing the hydration and take care of the hygiene. Very careful. So I think that will be my last slides. Thank you very much for your attention, and we will continue with the discussion. Thank you so much. So Professor Inzucchi, you're still here, right?
Yes, I am.
Okay, thank you very much. You can hear me clearly?
Yes, I can.
Okay, so is there any questions from the audience? Yes, please, Dr. Fauzan, and also you, Dr. Fauzan, first. Sorry. Could you help, please? You can talk loud. Oh, okay, that's good.
Assalamualaikum warahmatullahi wabarakatuh. Good morning,
Waalaikumsalam.
Dr. Wisma and Prof. Inzucchi. My name is Fauzan. I would like to throw two questions. The first question to Prof. Inzucchi regarding the potential effect of the SGLT2 inhibitors. You previously mentioned that there are many potential effects of SGLT2 inhibitors nowadays. Which effect is the most promising one? Because you previously mentioned that it is useful for gout arthritis and also pre-diabetes and muffled, which indication is also compelling between those potential effects. And the second question is regarding the use of SGLT2 inhibitors in daily practice to Dr. Wisma. In HF or in CKD, is there any superiority between empagliflozin or dapagliflozin in between those indications, or they are all the same in preventing those diseases? Thank you.
Thank you so much. Thank you very much. Professor Inzucchi, did you hear him?
Yes, I did. So
Okay,
I'll
thank
take
you.
I'll take the second question first. I personally don't think so. I think they're equally effective at the 10 milligram dose, DAPA and empagliflozin. There are some differences. I think the point estimate for the primary outcome was a little bit larger with DAPA, HF, as opposed to EMPEROR reduced. And I think there was a mortality benefit in one and not the other. But when you do clinical trials, you realize that some of these point estimates are quite labile. And as long as they're within the standard error of the hazard ratio or the confidence intervals, I think that they should be considered similarly. Unfortunately, there probably won't be a head-to-head trial, so we won't know for sure. But when you look at the hazard ratios across these trials, they appear to be very, very similar. And I say that mainly from the heart failure studies. It's interesting, from the diabetes cardiovascular outcome trials, the EMPA-REG outcome study had the largest effect on cardiovascular mortality. It was not replicated in any other of the SGLT2 inhibitors. Now, did we get lucky, perhaps, in the EMPA-REG outcome, or is empagliflozin stronger? I don't think we can answer that without a head-to-head trial. You'll notice that in the DECLARE study, the MACE outcome was actually not statistically significant. Now, that may be because they had lower risk patients in that study. So that's what I wanted to say about the relative effects in heart failure. And even in CKD, I think the effects are very, very similar. You asked a question I'm not sure I can answer. Which one is the most important of these, well, let's call them side benefits? I'm particularly interested in the nephrolithiasis effect. It's been demonstrated. We showed it with empagliflozin, and I think Danish investigators showed it in a real-world evidence study, that there was about a 40% decrease, I believe the risk reduction was, in new kidney stone episodes. I think that's a huge effect, and there are not a lot of good treatments for prevention of renal stones. It might have to do with citrate excretion, we don't know. But I think that's interesting. Whether that will ever be studied or become an indication, I can't tell you. I also am interested in the diabetes prevention effect, because I think there are so many additional benefits, weight reduction, blood pressure reduction, A1C reduction, that if you apply this medication to pre-diabetes patients, you might have a significant benefit in terms of preventing them from developing diabetes. It's interesting that the A1C lowering in the pre-diabetes study that we published was minimal. This is one of the few drugs that does not lower hemoglobin A1C in that range, in the normal range, yet still prevents diabetes. Now, how do you do that? It may be related to some altering of beta cell function from a reduction in glucose toxicity. It's really, really interesting. As you know, the GLP-1s appear to have a larger effect. So I think there's more interest in the obesity medications and the GLP-1s than the SGLT-2s. But the effect is very similar to what has been reported with metformin, as I mentioned, is 32% versus 31%. So those are the two that I'm most interested in, but I'm not sure if we can say it's the most important.
Condition for SGLT2 inhibitor in the future, but let's see when it's already established. Don't try it before it's established and it's approved by the BPOM. And I would like a little bit addition for the second questions. You have to remember about the populations of the study from the DAPA and EMPA. Not all of them is the same, because from the EMPA, almost all of them is already established CVD. But for the DAPA, there is a multiple risk factor population as well. So based on that, maybe you can think about this one maybe a little bit better for the primary preventions. And that one is probably better for secondary. It doesn't go that way, but based on the study, there is an indication, because there is a multiple risk factor in DAPA a lot more than in EMPA in PAREC outcome. So, yes, please, Doctor. Sorry, she's first.
Thank you, Dr. Wisma. My name is Insar. I would like to ask about if there's any research or any logic if the medication, this SGLT2, is preferably for male gender rather than female, because the outcome is quite gender in my personal opinion. And the second thing, if there's any study or pool sample that actually mentioned that this GLT2 beneficial for syndrome metabolic, because they already break down into more specific outcomes and specific populations. So I think that the syndrome metabolic idea is quite more widened. Thank you.
Did you hear the questions, Professor?
I heard the first one about men versus women. The
Yes.
second one was about metabolic syndrome and using this medication because it helps many aspects of metabolic syndrome.
Yes, yes.
Okay, I can tackle those. So my recollection of the subgroup analyses from all these trials shows that there is no differential effect between men and women, not a significant difference between men and women. So all respond adequately. One caveat is that women tend to get more of the genitourinary infections, specifically the genital yeast infection. So that is a higher side effect rate in women than men. But in terms of the benefit, I don't recall any of the SGLT2 inhibitor trials that suggested a better effect if you were a man or if you were a woman. In terms of metabolic syndrome, I think it's very similar to what I was saying before, which is the diabetes prevention. Obviously, metabolic syndrome is another way of saying insulin resistance. And if you lower glucose levels without increasing insulin levels, that's a way of addressing patients with hyperinsulinemia. Insulin levels will come down when you're using an SGLT2 inhibitor. Whether that mediates some of the diabetes prevention effects, I don't know. But yes, certainly the parameters of metabolic syndrome could be ameliorated with an SGLT2 inhibitor. But as we just said, I'm not encouraging the use of these medications in pre-diabetes or to prevent nephrolithiasis. I just find that it's interesting that when one conducts these post hoc analyses of these clinical trials, you see these interesting trends. And they would obviously need to be proven in a clinical trial before we can start using them in that regard.
Thank you. Thank you so much. So there is no doubt to use SGLT2 inhibitor in the patients with metabolic syndrome with diabetes. There is no doubt about that. But if you talk about metabolic syndrome, it's still not diabetes. But if you see one by one of the benefits of SGLT2 inhibitor, also there is no doubt that there will be benefits for them. But is it approved? Not yet. If you see one by one, there will be a lot of benefits using this for the patients with the metabolic syndrome. But again, if it's already DKD, then just give it. If it's already heart failure, then just give it. Okay, thank you very much. I think we could have one more, but the quick questions and quick answer, Professor.
Good morning, Dr. Inzucchi and Dr. Wisma. I would like to ask you, do SGLT2 inhibitor also offer clinical benefits in heart failure patient with major valvular abnormality? Since I have a elderly patient, 71 years old, with HFpEF caused by severe mitral regurgitation without comorbid like diabetes or heart hypertension, and no atherosclerosis.
Okay, thank you very much. I think the question is clear, Professor Inzucchi. Do SGLT2 works in the heart failure with the valvular heart disease instead of ASCVD? Please.
We don't know. There's no data. I suspect they would, based on how these medications work in heart failure. One study I can point to, I forget the acronym of the study, but it was a TAVR study. So patients getting transcutaneous aortic valve repair. Basically, the patients who were randomized to the, I forget if it was EMPA or dapagliflozin, it was you, I think it was dapagliflozin, actually had better outcomes post-TAVR. So that suggests that there may be a benefit beyond just atherosclerotic disease and beyond heart failure. But your specific question about valvular heart failure, there's no data.
Okay, thank you very much. I think we have to finish our session. So it has been really great to have you as our guest today. So thank you for coming, even I know it's very late in your place. Thank you very much for the audience. I think I'm not going to make a resume, but I think just a little bit that we know SGLT2 inhibitor usage now is very wide, but please be careful about the benefits and also about the risk. But please do not too careful and also too scared of using this SGLT2 inhibitor, because the benefits is a lot if you compare with the risk of SGLT2 inhibitor. So thank you very much. Sorry for the whatever the inconvenience that I caused. Wassalamualaikum warahmatullahi wabarakatuh. Thank you very much, Prof. Inzucchi.
Thank you. Bye-bye.
We would like to extend our heartfelt gratitude to the moderator and both speakers for the insightful and inspiring presentations. We hope today's discussion has provided valuable insights into the pleiotropic effects and practical application of SGLT2 inhibitors.
Okay, let us continue to our next session, which will be conducted in Bahasa. So let me deliver the next session in Bahasa. Baik, kita akan segera memasuki Symposium keempat dengan tema GLP-1 and obesity.